Welcome back to the deep dive. Today, we're plunging headfirst into a topic that has not only puzzled some of the most brilliant minds for centuries, but also carries an almost unimaginable human impact. We're talking about schizophrenia.
hmm
And to really drive home its profound severity, just consider this powerful quote from the journal Nature back in 1988. It describes it as arguably the worst disease affecting mankind, even AIDS not accepted.
Wow. That's quite a statement.
It's staggering, isn't it? Truly sobering.
It absolutely is. And, that quote isn't just hyperbole. It genuinely sets the stage for why this is such a critical area for us to understand more deeply. For far too long, schizophrenia has been shrouded in, well, misconception, fear, and just a profound lack of accurate information.
Yeah, definitely. Dispelling some of that fog is essential.
hmm
So our mission today is to pull back that veil, really, to provide clarity where there has often been confusion. This deep dive is, we hope, your comprehensive shortcut to being truly well-informed on schizophrenia. We're going to unpack exactly what it is, trace the fascinating and sometimes fraught evolution of its understanding, from those early, often quite grim concepts to our much more hopeful modern views.
Which is a huge shift.
It is. We'll explore its global prevalence, delve into its remarkably diverse clinical presentations, because, as you'll discover, it's far from being just one single thing.
Absolutely not. It's complex.
Then we'll examine the ongoing search for the underlying theories of its causes and critically discuss the modern approaches to management and the very real pathways to recovery that are now available.
And our goal here is really to sift through the history, the latest research, the clinical insights, and just bring you the most important nuggets of knowledge. We want to give you those aha moments, maybe some surprising facts,
Yeah.
all without, hopefully, overwhelming you with information overload. We've tailored this deep dive just for you, so you can truly grasp the nuances of this complex condition.
Exactly. So let's unpack this. Our journey begins, well, over a century ago, really, with the dawn of schizophrenia's scientific study. It might surprise you, to learn that while mental illness has existed forever, the systematic scientific approach to understanding conditions like schizophrenia is actually relatively modern. It's easy to think of modern medicine as having always existed in its current, very structured form, but the systematic study of what we now call schizophrenia is really only about a century old.
That's true.
While there were earlier descriptions of schizophrenia-like illnesses you can find references in, like ancient Ayurvedic texts describing similar conditions, and European physicians like Morel, Kalbaum, and Hecker had described things like demence, praecox, catatonia, and hebephrenia in the mid-19th century.
Precursors.
Right, precursors. But the real scientific grounding, the bedrock of our modern understanding, truly started with one individual, Emil Kraepelin.
That's right, Kraepelin. A towering figure in the emerging field of psychiatry back then. He arrives on the scene in 1896, and his major contribution was, frankly, nothing short of a paradigm shift in how we categorize psychiatric illnesses.
How so?
Well, before him, many severe mental conditions were often just lumped together in this kind of chaotic jumble. It made diagnosis and understanding incredibly difficult. Kraepelin, for the first time, really rigorously differentiated them into two main distinct clinical types, what he termed dementia praecox and manic depressive illness.
Ah, okay.
And this was groundbreaking because it brought a much-needed sense of order and structure. He essentially said, look, these are separate diseases, not just, different kinds of madness.
And his concept of dementia praecox specifically was pretty revolutionary for its time, wasn't it? He basically unified several conditions that were previously seen as distinct, like paranoia, catatonia, hebephrenia, under this one umbrella.
Exactly. He observed that despite their sort of different surface appearances, these conditions shared core features and, crucially, what he saw as a similar long-term trajectory. So he wasn't just listing symptoms, he was trying to identify a shared disease process.
Right. And his diagnostic emphasis for dementia praecox was heavily placed on an early onset and, well, unfortunately, what he perceived as an inevitably poor outcome.
Yeah, that's the key. The dementia part of the name referred to this perceived intellectual and emotional deterioration that he believed was irreversible, and praecox signified its early onset, typically in youth.
So it paints a pretty bleak picture.
He does. He meticulously detailed the characteristic features: delusions, hallucinations, disturbances of affect, emotional expression and motor disturbances, issues with movement. Use a rather grim, deterministic view, suggesting this feature of inevitable decline.
So Kraepelin gave us the first solid framework, even if it was, well, quite bleak initially. That sounds incredibly hopeless, frankly. Did anyone push back on that right away, or was that the accepted view for a while?
Kraepelin's view certainly dominated for a period, yeah. But it wasn't actually that long before a really pivotal shift occurred. Roughly 15 years later, Eugen Bleuler in 1911 took Kraepelin's dementia praecox
Ah.
and renamed it schizophrenia, which literally means mental splitting. And this wasn't just swapping labels, it represented a fundamental reevaluation of the disorder and, importantly, a challenge to Kraepelin's deterministic prognosis.
That's where it gets really interesting, right? Because Bleuler's crucial insight was that this disorder did not always have the poor prognosis Kraepelin described.
Exactly. He observed patients who actually experienced significant recovery or at least substantial improvement. That directly challenged the old view of inevitable decline.
And he also recognized it wasn't just one single uniform disease, but rather a group of schizophrenias.
Acknowledging the immense variability in how it presents, its course, its outcome. This was a critical step away from seeing it as one irreversible illness, towards seeing it as more of a spectrum of disorders, which is much closer to how we see it today.
Definitely. And it was Bleuler who introduced his fundamental symptoms, often remembered as the 4 A's, right? Which he thought were really central to the illness.
Yes, the 4 A's. First, there's ambivalence, this marked inability to decide for or against something. A profound internal conflict that can just paralyze action. Imagine being stuck, unable to move forward on even simple decisions because these equally strong, contradictory impulses are pulling you apart.
That sounds exhausting. Then you have autism, but not autism as we know it today.
Right, important distinction. In Bleuler's context, it meant this profound withdrawal into oneself, a preoccupation with an inner private world, often detached from external reality, retreating into fantasies or internal logic, making connection difficult.
Okay. And the 3rd A?
Affect disturbances, like inappropriate effect. So imagine someone hearing devastating news, like a loved one passing, and they giggle, or show no emotion at all, just a flat expression. It's this profound disconnect between their emotional expression and the actual situation. Makes it very hard for others to relate.
Yeah, I can see that. And the last one?
Association disturbances. Bleuler thought this was the most fundamental. It's the loosening of associations, a key thought disorder, where ideas just don't flow logically anymore. The connections between thoughts become fragmented, disjointed.
Leading to confusing speech.
Exactly. And if it gets severe, the speech can become basically incomprehensible. That's what we call incoherence. What Bleuler really showed with his 4 A's wasn't just symptoms. It was this fundamental disintegration of the connections between thoughts, feelings, self, and reality. A core disruption.
A profound internal unraveling.
Precisely. So Kraepelin gives us the first systematic view. Bleuler broadens it, challenges the prognosis, defines the splitting. But then the clinical picture got even more refined with Kurt Schneider in 1959. He added another layer with his first-rank symptoms, or SFRS.
Schneider's contribution wasn't really to redefine schizophrenia, was it? It was more about describing a set of symptoms that were just really helpful in making the diagnosis clinically.
Exactly. He said they were of great help, even if they weren't specific only to schizophrenia, meaning you could see them elsewhere. But they were so striking, so indicative of severe thought disturbance, that their presence often strongly pointed towards schizophrenia. They gave clinicians clearer signposts.
And these symptoms, they really offer a glimpse into just how profoundly altered reality can become for some individuals, like audible thoughts or thought echo.
Yeah, where a person hears their own thoughts spoken aloud by voices. Imagine having zero privacy, even in your own mind. Your thoughts broadcast.
It's terrifying.
Or voices heard arguing, where two or more voices discuss the person, the patient, in the third person. Like they're eavesdropping on a conversation about themselves. Or voices commenting on one's action, like a running commentary on everything you do.
An unseen narrator.
Pretty much. Constant invasive commentary. These aren't just noises. They're complex, interactive, often deeply distressing.
And the thought disturbances sound equally disorienting, thought withdrawal.
Where thoughts feel suddenly plucked out of your mind by some external force, leaving you blank. Thought insertion, where alien thoughts feel implanted, not your own. And thought diffusion, or broadcasting that terrifying feeling your private thoughts are leaking out, being experienced by others. A total loss of mental boundaries.
Wow.
Schneider also described these made phenomena. Made feelings, impulses, or volitions where you experience your own emotions, urges, or actions as being controlled by an outside force. Like your hand moving, but someone else is controlling it.
Like a puppet.
Sort of,
Yeah.
yeah. And somatic passivity, where bodily sensations feel imposed like electricity flowing through you that isn't real. And finally, delusional perception. This is a weird one. A normal perception, like seeing a red car, suddenly takes on this private, illogical, deeply significant meaning, like, the red car means I'm the chosen one. Not a misinterpretation, but a sudden, intense personal meaning attached to something ordinary.
It's fascinating how these first-rank symptoms really shaped diagnostic criteria for so long. They helped clinicians spot these really striking presentations. But as you said, and the source points out, they're not pathognomonic.
Crucial point. You can see them in other conditions like severe mood disorders or organic issues, but they definitely painted a vivid picture of that internal world during severe psychosis.
Yeah.
Hashtag the global reach in clinical manifestations.
That's a great transition, actually, because understanding the symptoms naturally leads us to, well, the global scale of this challenge. When we talk about epidemiology, the numbers involved are kind of
They
staggering.
really are. According to the World Mental Health Report from 2001, roughly 24 million people worldwide suffer from schizophrenia.
24 million, that's larger than many countries.
It is. It puts it in perspective. The point prevalent of, so the number of people with the condition at any given time is about 0.5% to 1% of the population.
And it's everywhere, right? Not just localized.
Pretty much everywhere. It's prevalent across racial, sociocultural, national boundaries. Very few exceptions. It's truly a global condition.
And the incidence.
New cases.
About 0.5 per 4,000 people per year. What's also interesting is the gender difference. While it affects both men and women, the onset is usually a bit later in women, and often the course seems relatively more benign compared to men.
Why might that be?
Well, it suggests there could be biological factors, maybe hormonal influences, or perhaps differing social pressures, or different ways symptoms are expressed or tolerated. It's still being explored.
Okay, so we know it's widespread, but what does it actually look like? When we talk clinical features, we're talking about a whole constellation of disturbances, aren't we?
Exactly. Affecting thought, speech, perception, emotion, motor behavior, that fundamental connection to the external world. And here's the really important thing to stress again. The diagnosis is entirely clinical.
No blood test, no scan. Nope. No single marker says this is schizophrenia. It's based on a careful assessment of this complex pattern of features. And none of these features alone is enough. It's the combination, the persistence, the impact.
Right. It's the whole picture.
Absolutely. So let's delve into some of the most characteristic ones. The disorders of thought and speech, the disjointed mind. One classic feature is autistic thinking.
Where thinking follows private, illogical rules.
Exactly. Independent of shared reality or logic. The source gives that classic von Domerus law example. Lord Hahnemann was celibate. I am celibate too. So I am Lord Hahnemann.
That logic leap is wild, completely personal.
It illustrates that break from conventional reasoning perfectly. Then there's loosening of associations, where ideas just don't connect meaningfully. The glue holding thoughts together seems to dissolve. Speech becomes disjointed.
And if it's severe, it becomes...
Incoherence, or word salad, virtually incomprehensible.
Then there's thought blocking. That's really distinct, isn't it?
Very. A sudden interruption of speech, mid-thought. Then, after a pause, the person just can't recall what they were saying.
Yeah.
Like hitting a mental wall. It's frightening for them, confusing for the listener.
And what about neologisms, making up words?
Yeah, newly formed words that others can't understand the origin of, created to express a concept they don't have a word for. Sometimes it's using normal words unconventionally, but you can kind of figure it out, word approximations or paraphrases, like calling a stomach a food vessel.
The verbal behavior disorders can vary a lot, too, from complete silence.
Mutism, yeah. Or poverty of speech, just very little speech. Or poverty of ideation, where there's speech, but it's vague, empty, conveys little information.
And the echoing.
Echolalia.
Yeah.
Involuntarily repeating the examiner's words.
Yeah.
And perseveration, getting stuck on a word or idea long after it's relevant. Or verbigeration, senseless repetition of words or phrases over and over.
Okay, moving from the flow to the content. Delusions. These are fundamental, right? False, unshakable beliefs.
Absolutely. And not in keeping with their background. Persisting despite evidence. 2 types. Primary delusions arise suddenly, out of the blue, seemingly unexplained, often seen in early acute phases.
And secondary.
Secondary delusions are more common, arising from other experiences like hallucinations, so they're not diagnostic on their own.
And the themes are often quite specific. Persecution, reference.
Very common. Delusions of persecution,
Yisha.
believing you're being harmed, conspired against. Delusions of reference, random events or specifically about you have personal meaning. Delusions of grandeur, believing you're godlike, famous, have special powers.
Delusions of control, feeling like a puppet.
Exactly.
Yeah.
Thoughts, actions, emotions controlled by an external force. And somatic delusions, false beliefs about your body, infestations, rotting organs, bizarre things, despite medical evidence.
There are other thought issues too, right? Like over-inclusion.
Yeah, getting lost in irrelevant details. Impaired abstraction, leading to concreteness, taking everything literally. Ask what brought you here. They say, a bus, not their symptoms. Feelings of perplexity, profound confusion, ambivalence, like Bleuler's A, and Schneider's first-rank symptoms we talked about, thought insertion, withdrawal, broadcasting, all profound thought disturbances.
Which brings us neatly to disorders of perception, hallucination.
Perceptions without stimuli, very common. Auditory hallucinations are the most frequent.
Voices?
Can be, from simple sounds, buzzing, clicking, to complex things like thought echo, hearing thoughts aloud. But the ones thought most characteristic are the third-person hallucinations.
Voices arguing about you or commenting on what you do.
Exactly. Like having this constant, often critical commentary in your head, incredibly distressing, makes it hard to know what's real.
And while auditory are most common, others can happen.
Yes, less frequently.
Visual.
Seeing things, tactile, feeling things like bugs crawling,
Yeah.
gustatory tasting things, olfactory, smelling things, often unpleasant, makes everyday life potentially terrifying.
Then there are the disorders of affect. Emotional dysregulation.
Profoundly impacts expression and experience.
Yeah.
Apathy, lack of interest, emotional blunting, severely reduced expression, flat appearance, emotional shallowness, superficial responses, anhedonia.
The inability to feel pleasure.
Right, even from things once enjoyed. And inappropriate emotional responses, giggling at bad news. This difficulty connecting emotionally really impacts relationships, rapport, even with doctors.
And it affects motor behavior too. Can go either way.
Yes, a significant decreased spontaneity, inertia, even stupor, being immobile. Or conversely, an increased excitement, aggressiveness, restlessness, agitation, often non-goal directed.
And you see things like mannerisms, odd gestures.
Mannerisms, grimacing, stereotypes, repetitive, purposeless behaviors like rocking. Also often decreased self-care, poor grooming, as motivation and ability decline.
This leads into negative symptoms, which you mentioned can be particularly insidious.
They are, because they're a loss or absence of normal functions, often subtle, but hugely impactful long-term. Unlike positive symptoms like hallucinations, which are added, these are subtractions.
Like affective flattening or blunting.
Yeah, reduced emotional expression, flat voice, unchanging face. Attentional impairment, difficulty focusing, avolition, apathy, lack of initiative, motivation. Anhedonia again.
Yeah.
Asociality, social withdrawal. And alogia, lack of speech output or very little content.
And the impact of these negative symptoms is huge on daily life.
Absolutely. Poor communication, verbal and nonverbal.
Yeah.
Less eye contact. Poor self-care.
Yeah.
Social isolation. It's an erosion of engagement with the world. Hard to maintain relationships, jobs, even basic hygiene. And they're often harder to treat than positive symptoms, contributing a lot to long-term disability.
Okay. And other diagnostic features, like functioning.
A noticeable decreased functioning from previous levels, work, social, self-care. Often a loss of ego boundaries, that blurring between self and environment, uncertainty about identity, multiple somatic symptoms, strange bodily complaints, especially early on.
And insight is usually poor.
Yes, insight is usually absent or impaired. They often don't believe they're ill. Makes treatment adherence a real challenge. Social judgment is typically poor too.
But consciousness, memory, intelligence are usually okay.
Generally, yes. No significant disturbance there, which helps distinguish it from delirium or dementia. Symptoms can wax and wane, be highly variable, and crucially, no obvious organic cause, no prominent mood disorder that better explains things.
And we have to mention the risk of suicide. It's significantly higher, isn't it?
Critically important point. The risk is much higher. Can be due to comorbid depression, terrifying command hallucinations, impulsivity, profound anhedonia making life feel meaningless, or even paradoxically, the return of insight, that painful awareness of the illness and its impact.
So awareness and addressing that risk is vital in management.
Absolutely essential.
So given this really complex mix of symptoms, how do clinicians actually make the diagnosis? You mentioned the criteria, ICD-10 versus DSM.
Right. The major systems differ slightly, mostly on duration. ICD-10 generally needs clear symptoms for about a month or more. DSM-IVTR historically required 6 months.
And if it's less than a month?
Usually diagnosed as an acute schizophrenia-like psychotic disorder. But importantly, for any schizophrenia diagnosis, you have to rule out other things first.
Like brain diseases, drug issues, mood disorders.
Exactly. Rule out organic causes, substance issues, or if a major mood disorder better explains the psychosis. It's about the whole clinical picture and excluding alternatives.
Makes sense. Now, the clinical types, the subtypes, it's not just one thing.
Definitely not. Classified into subtypes based on predominant symptoms. Historically, catatonic and hebephrenic were called nuclear schizophrenia, seen as typical, often leading to severe deterioration if chronic.
Okay, let's break them down. Paranoid schizophrenia.
Primarily characterized by prominent, well-systematized delusions, often persecutory, feeling harmed or plotted against, but can be grandiose, reference, control, infidelity. Hallucinations, if present, usually echo the delusional themes. And what makes it distinct, prognosis-wise?
Typically, no prominent disturbances of affect, volition, speech, or motor behavior. Less personality deterioration than other types. Onset is often insidious, gradual later in life, late 20s, early 30s. Course tends to be progressive, complete recovery is rare, but remissions and relapses are common. Needs ongoing management.
Okay. Then disorganized or hebephrenic schizophrenia.
This one's marked by severe thought disorder, often incoherent speech, severe loosening of associations. Delusions and hallucinations are usually fragmented, fleeting, changeable, not systematic like in paranoid type.
And emotional.
Very prominent emotional disturbances. Inappropriate affect, that's senseless giggling. Or profoundly blunted affect, bizarre mannerisms, mirror gazing, disinhibited behavior, poor self-care, extreme social withdrawal.
And the prognosis here is less good.
Generally, yes. Onset is insidious, usually early teens. Course is classically progressive, downhill with severe deterioration, often considered to have one of the worst prognoses among the subtypes. Leads to profound impairment. Right. Then catatonic schizophrenia, defined by motor disturbances.
Exactly. Marked disturbance of motor behavior. Can be dramatic. Present in 3 forms. Excited catatonia, stuporous catatonia, or alternating between them.
Excited catatonia sounds intense.
It can be. Significant increase in psychomotor activity, restlessness, agitation, aggression, even violent furor. Increased speech, pressure, loose associations, incoherence. Crucially, the excitement isn't goal-directed, seems driven from within. Historically, acute lethal catatonia was a risk, severe excitement, rigidity, hypothermia, dehydration, potentially fatal. Much rarer now with modern treatments.
And the opposite, stuporous catatonia.
Extreme psychomotor retardation. Classic catatonic signs.
Yeah.
Mutism, no speech. Rigidity, maintaining posture against efforts to move. Negativism, motiveless resistance, doing the opposite. Posturing, assuming bizarre postures for long periods.
And stupor itself, unresponsive but aware.
Often, yes. Akinesis, mutism, but preserved awareness internally. Other signs. Echolalia, echoing words. Echopraxia, echoing actions. Waxy flexibility or catalepsy limbs maintain positions they're placed in, like wax. And emittendency, conflicting impulses, getting stuck mid-action.
What's the course like for catatonic?
Usually acute onset, late teens, early 20s. Often episodic periods of illness and remission. Recovery from episodes is often complete, but residual features might remain after multiple episodes. Untreated catatonia can lead to serious physical problems.
Okay. Next, residual schizophrenia and simple schizophrenia.
Residual is diagnosed after at least one acute episode. It's characterized by prominent negative symptoms, while the florid positive symptoms, delusions, hallucinations, are absent or much reduced. Important to rule out if these negative symptoms are due to meds, depression, or institutionalization.
And simple schizophrenia, hard to diagnose.
Very difficult, because it lacks the dramatic positive symptoms. Early onset, early teens, insidious progressive course, dominated by marked negative symptoms. Severe social withdrawal, shallow affect, loss of initiative, vague health complaints, downward social drift, declining function, aimlessness, homelessness sometimes. Hallucinations usually absent or brief. Prognosis is generally very poor due to those persistent negative symptoms.
Another important one, post-schizophrenic depression.
Yes, when depressive features develop within 12 months of an acute episode, often alongside residual symptoms. Concerning because of the significantly increased suicide risk. Crucial to distinguish it from negative symptoms or medication side effects as treatment differs.
And historically, there were others, like
Yeah.
schizophreniform disorder.
Right. Similar to schizophrenia, but duration is shorter, less than 6 months, often has a better prognosis. Van Gogh syndrome, dramatic self-mutilation, named after the painter.
And the type 2 distinction.
That was proposed by T.J. Crow. Type 1, mostly positive symptoms, acute onset, good medication response, better outcome. Type 2, mostly negative symptoms, chronic, poor med response, maybe brain changes like dilated ventricles. Theoretically useful, but
Limited validity now.
yeah, recent research finds most patients are a mix. Pure types are rare, so the rigid distinction isn't that helpful clinically anymore.
This brings us to a really crucial point: prognosis and outcome. For so long, because of Kraepelin's dementia praecox idea.
Yes, the assumption was this relentless downhill course led to institutionalization, pessimism,
But modern understanding is much more optimistic, isn't it? It challenges that legacy.
massively. Longitudinal studies following patients for many years show Kraepelin's pattern is actually a minority outcome. That big Luc Chiampi study from 1980, following over 5,600 cases for nearly 37 years, it completely broke that old paradigm.
What did it find?
The results were striking. 27% achieved complete remission, few or no symptoms, functioning well. Another 22% had remission with only minor residual deficits, living largely independently.
So almost half reached complete or near complete recovery.
Exactly, almost 50%. Only 18% were left with severe disability, and just 9% needed long-term institutionalization. A huge departure from the old view. A real aha moment for the field.
And other studies show similar things, especially outside the West?
Yes, like the Indian Council of Medical Research SOFACOS study. 386 patients, 5 years. 27% had a very favorable outcome. Another 40% favorable. That's about two-thirds, 67%, with a favorable outcome. Even better than Chiampi's findings sometimes.
And the International Pilot Study on Schizophrenia, IPSS, that found better outcomes in developing countries.
It did. Compared Nigeria and India to developed countries, outcomes were often better. Raises questions about culture, family support, stigma, diagnostic practices, maybe a combination. Challenges the idea of a single universal outcome.
So what does this mean for someone diagnosed today or their family? There's real hope.
Absolutely. And understanding the factors influencing outcome is key. There are definite good prognostic factors. Acute abrupt onset, not gradual. Onset after age 35. A clear precipitating stressor. Good premorbid adjustment functioning well before the illness.
Certain subtypes.
Catatonic often has better recovery between episodes. Short duration of untreated illness less than 6 months is crucial. Predominance of positive symptoms, which respond better to meds. Female sex, good social support. And critically, proper treatment adherence. It's a mix of biology, resilience, environment.
And conversely, poor prognostic factors.
Insidious onset, gradual over years. Onset before age 20. Absence of a clear stressor. Poor premorbid adjustment.
Subtypes again.
Disorganized hebephrenic, simple, undifferentiated chronic catatonic, usually worse due to negative symptoms. Chronic course, over 2 years without remission. Predominance of negative symptoms. Male sex. Poor social support, being unmarried. And especially lack of proper treatment or poor adherence underscores the need for early sustained care.
Now, despite these more hopeful recovery rates, we have to talk about mortality and morbidity. They are higher.
Significantly higher, unfortunately. Almost 1.5 times higher mortality rate than the general population. Not just the illness itself, but broader health impacts.
And the leading cause of premature death is suicide.
Tragically, yes. Lifetime risk is 5 to 10 times higher. But it's not just suicide. There's also a much higher prevalence of metabolic syndrome.
That cluster. Obesity, cholesterol issues, high blood pressure, glucose problem.
Right. Often worsened by antipsychotics. Increases risk of heart disease, diabetes.
Lifestyle factors play a big role too. Smoking, diet.
Huge role. High rates of smoking, caffeine use, substance misuse, obesity, coupled with poor treatment adherence for physical issues, poor help-seeking, decreased activity due to negative symptoms.
It all adds up.
It does. The combined effect means patients can die 10 to 15 years prematurely. It's sobering.
Really highlights the need for holistic care, not just psychiatric.
Absolutely. Integrated care addressing physical health, lifestyle, social factors. And again, the longer the DUP duration of untreated psychosis, the worse the outcome, psychiatrically and physically. Early diagnosis and treatment are vital.
Okay, so we've looked at what it looks like, the course, the impact. Now the big question, what causes it? And the short answer is, we don't know exactly.
That's the upfront answer. Yeah. The exact single cause is unknown. It's complex, likely multiple factors interacting. But we have many theories, biological, psychological, sociocultural, each adding a piece to the puzzle.
Let's start with biological theories. Genetics seem pretty strong here.
Very strong evidence.
Yeah.
Much higher rates in relatives, about 8–10% in first-degree relatives, parents, siblings, kids, versus 0.51% in the general population. A tenfold increase is significant.
And the twin studies,
Really powerful. Identical twins share nearly 100%. Genes concordance rate is around 46%.
Hmm.
Fraternal twins share about 50%. Like regular siblings, concordance drops to about 14%. That difference points strongly to genetics.
And parental risk.
10–12% chance if one parent has it. Jumps to about 40% if both parents have it. Very high statistical likelihood.
So genetics create a vulnerability, but aren't the whole story.
Exactly. Creates vulnerability, a predisposition. But the fact identical twin concordance isn't 100% tells us genes aren't solely determinate. Environment, stress likely play a crucial role in precipitating episodes in vulnerable individuals. Nature and nurture.
Okay. What about biochemical theories? The dopamine hypothesis has been dominant, right?
Hugely influential. The current thinking is it's probably related to a functional increase of dopamine activity at postsynaptic receptors, especially in certain pathways like the mesolimbic system. Maybe not more dopamine, but maybe more sensitive receptors or an imbalance.
But it's not just dopamine.
Probably not. Other neurotransmitters are implicated too, suggest a broader picture. Serotonin, especially 5-HT2 receptors, GABA, acetylcholine. Newer meds often target multiple pathways, reflecting this complexity.
And brain imaging, what does that show?
It helps visualize differences. CT, MRI, postmortem studies in some patients show things like enlarged ventricle, the fluid spaces, though not like hydrocephalus, also mild cortical atrophy, a slight reduction in brain volume, maybe 5–10% in some areas.
And functional scans like PT?
They show activity. Findings include hypofrontality, decreased activity, less energy use in the frontal lobes, especially during thinking tasks.
The brain CEO, affecting planning, decision-making.
Exactly. Offers clues to why people struggle with executive functions, motivation, managing thoughts, emotions. Also see decreased glucose use in the dominant temporal lobe. But, vital point, imaging currently doesn't confirm a diagnosis. Its main clinical use is ruling out organic causes, tumors, infections, etc.
Got it. Rule out, not rule in. What other biological findings support this?
Well, antipsychotics work primarily by blocking dopamine D2 receptors. That causes improvement, prevents relapse. Newer atypicals often hit serotonin, 5-HT2.
And certain drugs can mimic symptoms.
Yes, amphetamines, mescaline, the increased dopamine, can cause schizophrenia-like symptoms. Also, some organic disorders, Huntington's, Wilson's disease, can present similarly. Need careful differential diagnosis. We also see more soft neurological signs, minor physical anomalies, impaired eye tracking in patients, hinting at subtle neurodevelopmental differences. Viral, autoimmune, neurodevelopmental hypotheses are also still being researched.
So a strong biological foundation, but psychological theories are important too, especially for triggering.
Definitely. The stress vulnerability hypothesis is key here. It suggests increased stressful life events can act as a trigger in someone already genetically vulnerable.
Like the leaky bucket analogy, higher vulnerability, less stress needed.
Precisely. It's that interaction. Helps understand how biology translates to illness and guides psychosocial interventions too.
And a major environmental stressor studied is expressed emotions in families.
Yes. High levels of hostility, critical comments, emotional over-involvement from significant others. Not blaming families, but identifying impactful patterns.
The Vaughan and Leff study showed a huge impact on relapse.
Compelling evidence. Patients off meds with high E contact, 35 hours a week, had a 92% relapse rate in 9 months, compared to only 12% with meds and less EE. Replicated globally, though maybe not the exact hour threshold, the principle holds. High-stress family environment contributes to relapse, highlights the interpersonal impact.
Important to mention those historical family theories that were damaging and are now discredited.
Absolutely. Schizophrenogenic mothers, the double-blind theory, these unfairly blamed parents, cause unnecessary guilt. Not considered valid now, largely abandoned.
What about the information processing hypothesis, issues with attention?
Suggests fundamental disturbances in attention, difficulty filtering, integrating perceptions. Maybe initially over-attentive, then overwhelmed, leading to breakdown in processing reality coherently. Breakdown in internal representation.
And psychoanalytical theories, historically relevant.
Like Freud's ideas of regression, loss of ego boundaries. Discussed historically, but not the current consensus for routine treatment or understanding. Modern views largely neurobiological and biopsychosocial.
Finally, sociocultural theories. Prevalence is uniform, but higher rates seen in lower socioeconomic status.
Yes, but that's largely explained by downward social drift. The illness causes the drift down the social ladder due to impaired functioning, not poverty causing the illness.
And higher rates in migrant populations.
Seen in first and second generations. Suggests complex interplay. Genetic vulnerability plus stresses of migration, assimilation, discrimination, adaptation challenges, all potential stressors. Okay, so given all this complexity symptoms causes the really good news is that modern management offers significant pathways to recovery and well-being. It truly challenges those old, grim prognoses. Treatment is comprehensive, falling under two main interconnected headings: somatic, mostly medical, and psychosocial, focusing on rehab and support.
Let's start with the backbone. Somatic treatment, mainly pharmacological. It's fascinating that the first drug with benefits was reserpine from a plant used in India back in 1931.
Yeah, Rowolfia serpentina, used for sedative properties, not used now in the West due to side effects, better options available.
But the formal discovery of antipsychotics in 1952 by DeLay and Denneker, that was the game changer.
Absolute game changer. Profoundly changed the outcome. Suddenly, there was a way to manage those florid, positive symptoms. Hallucinations, delusions, made it possible for people to leave institutions, integrate into the community. Unimaginable for many before that.
And today we have different generations, atypical versus typical.
Right. Atypical or second generation, like risperidone, olanzapine, quetiapine, aripiprazole, ziprasidone, more commonly used now than older typical or first generation, like haloperidol, trifluropazine. Atypical is often better for negative symptoms, different side effect profile.
And clozapine is particularly important for treatment resistance.
Very important. Effective in about 30% who don't respond to others. Crucial last line option. But comes with significant side effects. Granulocytosis, that dangerous drop in white blood cells. Seizures needs regular blood monitoring. Used carefully.
Most treatment is outpatient now.
Mostly, yes. Allows people to live in the community. Hospitalization is for specific acute situations. Dangerous neglect of food, water, danger to self-others, severe relapse due to poor adherence, severe self-neglect or lack of support with these risks present. Goal is always least restrictive environment.
And managing acute excitement.
Rapid tranquilization protocols might be used haloperidol and IVIM, maybe with diazepam or promethazine. Need careful monitoring, especially if new to meds. Oral meds generally preferred unless immediate tranquilization needed or adherence is the main issue.
Maintenance treatment is essential for preventing relapse.
Absolutely critical. Schizophrenia is chronic for many. Stopping meds often means symptoms return. Duration varies. 6-12 months for a first episode, 1-2 years for subsequent, maybe indefinite lifelong for repeated episodes or persistent symptoms. Highly individualized decisions, weighing benefits and risks.
And depot antipsychotics help with adherence. The long-acting injections.
Invaluable tool. Release medications slowly over weeks or months. Patient doesn't have to remember daily pills. Significantly reduces relapse risk from missed doses.
And managing side effects, especially the Parkinson's-like ones with older drugs.
Yeah, extrapyramidal side effects, EPS, often need adjuvant anti-Parkinsonian meds like trihexyphenidyl, especially with older typicals. But caution with anticholinergics can worsen cognition, abuse potential, cause delirium, worsen negative symptoms, maybe increase risk of tardive dyskinesia, that permanent movement disorder.
Yeah.
Ideally only used if side effects appear.
And the mechanism. Blocking dopamine.
Primarily blocking postsynaptic dopamine, D2 receptors, in the mesolimbic system helps positive symptoms. Atypicals often hit serotonin too, hence serotonin-dopamine antagonists, SDAs.
Beyond meds, electroconvulsive therapy, ECT, still have a role.
A crucial role, but not first line for schizophrenia itself usually. It's for specific severe situations. Profound catatonic stupor or uncontrolled excitement, acute exacerbations not controlled by drugs, or severe drug side effects preventing adequate treatment. Can be life-saving. Typically 8-12 sections, 2-3 times a week.
And historical treatments like megavitamins, insulin coma, abandoned.
Largely abandoned. Poor efficacy or significant risks. Psychosurgery is extremely rare now, absolute last resort for very severe intractable cases, like severe depression, anxiety resistant to everything else.
Okay, that covers the somatic side. But effective management heavily relies on psychosocial treatment too.
Hugely important component, an adjunct to medication. Significantly enhances drug efficacy, leads to more complete recovery and rehabilitation, but important. Psychosocial treatment alone is unlikely to be effective for most. They work hand in hand.
Starts with psychoeducation for patient and family.
First and vital step, educating patient and family with consent about the illness, course, treatment rationale, builds therapeutic relationship, explains the stress vulnerability model, empowers families, reduces guilt.
Group psychotherapy for skills.
Often aimed at teaching problem solving, communication skills, sometimes called social skills training, practice navigating social situations, coping strategies in a safe group setting, role-playing job interviews, starting conversations.
Family therapy goes beyond education, focuses
Yeah.
on communication, e.e.
Exactly. Enhances communication within the family, aims to decrease expressed emotions, reducing critical remarks, over-involvement, hostility, creates a calmer home environment, reduces relapse, building a healthier system.
Milieu therapy, the therapeutic community idea.
Treatment in a structured living, learning, working environment, inpatient units, day hospitals, halfway homes. The whole environment is therapeutic, provides support, skill practice, gradual reintegration.
Individual psychotherapy is usually supportive.
Generally supportive. Coping strategies, resilience building, emotional support. Psychoanalytic therapy isn't routinely recommended for schizophrenia now.
But cognitive behavior therapy, CBT, is increasingly recommended.
Yes, as a crucial adjunct to meds. NICE guidelines support it. Requires specialized training. Helps challenge distressing delusions, hallucinations, improve thought patterns, develop adaptive behaviors, empowers patients.
And finally, psychosocial rehabilitation, getting back function.
Often used with milieu therapy. Helps regain function, independence. Includes activity therapy, work habits, leisure, vocational training, retraining, vocational guidance, job placement, independent, sheltered, self-employment, occupational therapy for daily living skills, finances, cooking, hygiene.
So the overall message is clear. Meds are the mainstay, but psychosocial treatment is indispensable for enhancing efficacy and leading to fuller recovery.
Absolutely. It's a holistic, integrated approach. Acknowledges the multifaceted nature, offers the best path for individuals to reclaim their lives. Hashtag, tag, #.
So as we bring this deep dive to a close, we've really journeyed from those earliest, often quite grim concepts of schizophrenia
Yeah.
to a far more nuanced, integrated, and, well, profoundly more hopeful understanding today.
Mm-hmm.
What started with Kraepelin's dementia praecox, seen as this relentlessly deteriorating condition, has evolved through Bleuler's recognition of a group of schizophrenias, Schneider's detailed clinical work. And today we see it as this complex group of disorders, varied presentations, multifaceted causes.
And importantly, often remarkably favorable outcomes when met with comprehensive integrated care. That's the key takeaway.
Exactly. We've seen how genetics create vulnerability, how brain chemistry plays a role, and how environment stressors, family dynamics can really influence the course.
And critically, the huge advancements in treatment, from those revolutionary antipsychotics to the vital psychosocial interventions, psychoeducation, family therapy, vocational rehab, all working together.
The shift in understanding, from that guaranteed downhill course to studies showing such high rates of recovery, it's truly a testament to scientific progress, isn't it? And human resilience.
Absolutely.
And that leaves us with maybe a final provocative thought for you, the listener, to ponder. Given these profound advancements, especially this dramatic shift from Kraepelin's grim outlook to data showing high recovery rates, how can society better adapt?
Good question.
How can we dismantle the persistent stigma, ensure individuals living with schizophrenia get not just cutting-edge care, but also the societal understanding, the support, the opportunities they need to achieve their fullest potential, to lead meaningful, integrated lives?
It's a question for all of us, really. Moving forward, ensuring scientific progress is matched by societal compassion and genuine support.
Couldn't agree more. Thank you for joining us on this deep dive into schizophrenia. We truly hope you feel much more informed and maybe empowered with this knowledge. Until next time. Welcome back to the deep dive.